So starting with that, our first panel is here to talk about trends in technology and directions for on-site, near-site virtual centers. So with that, I'm going to ask each of them to introduce themselves, and then we'll go into an interactive discussion. So Jason, can you start?
Good morning, everyone. Jason Perot. I'm with Vita Health, which is a virtual whole health solution based out of San Francisco. But I've been there for a little over 2 years. Prior to that, I spent nearly a decade at the Boeing Company leading healthcare well-being strategy, which encompassed on-site and near-site clinic opportunities. And then prior to that, a little over 18 years at AT&T.
Hassan?
Good morning, everyone. Hassan Azar. Like Jason, I'm an ex-benefits leader. I was at Ford Motor Company, Kraft Foods, and US Foods, where we had clinics. Currently, I'm working with the Employer Health Innovation Roundtable, which is 110 Fortune 500 companies that are looking for the next best thing, innovation in health benefits globally. So helping them find solutions to improve their health.
Thank you. Carl?
Good morning, Eris Spear with WTW, Willis Towers Watson. I am our practice leader for on-site near-site health. At WTW, we're a global consulting firm working with employers across a number of areas, including health and benefits. So our on-site near-site team works with employers around starting health centers, feasibility, can you get to an ROI with a health center, looking at existing centers, vendor procurements, and so forth.
Thank you. Jeff?
Jeff Wells. I serve as the Chief Executive Officer. I'm one of the co-founders for Marathon Health. We're an advanced primary care organization that does population health management with employers. Operate about 230 physical health centers in virtual care sort of throughout the country. I'm a primary care physician by background and spent a little bit of time on the payer side leading a Medicaid program before getting involved with Marathon. So great to be here.
Thank you. Phil?
Good morning, everybody. Phil Berry, founder, CEO of Northwind Pharmaceuticals. Just hit our 15-year mark. The Northwind, very good thing. We are a national pharmacy services platform that is focused on removing the access, cost, and complexity barriers that our members and our employer clients face in the marketplace. We serve clinic groups with medications and programs around what they're doing in population health. We also have a clinically driven model that is about bringing our clinical blueprints to bear to help patients actually navigate and access the medications and get the care that they need as they need it. So very excited to be here today.
Great, thank you very much. Yeah, and so our approach again for this is going to be to ask a series of questions, and then if you have questions for the panelists or something, we'd say again, just text me, or if you can, write the notes on the cards. So let's just start out in generally. So what new technologies now exist that are impacting the delivery and quality of healthcare, specifically worksite centers? Jason?
Yeah, I would say in the past decade, we've seen this massive evolution with technology. When we think about how do we pivot from brick and mortar, traditional healthcare delivery to a hybrid approach that certainly leverages that, but also provides a virtual overlay when we think about remote patient monitoring or just providing people where they may prefer to be met, whether it's chronic condition management, mental health, or even physical preventive lifestyle health coaching. So that overlay and integration, I think, is essential when we think about how can we best meet not just our employees, but the covered dependents that we're also serving from an employer perspective in the best way possible. So that's come a long, long way, and we've seen statistical evidence-based outcomes proving out that digital cognitive behavior therapy, for example, is absolutely effective. And if anything, we've seen a learning lesson off the pandemic that supports that and substantiates the sustained trajectory of utilization in that area alone. But we've definitely branched far beyond just primary care from an on-site, near-site clinic perspective into other areas of need like MSK, physical therapy, as well as mental health, whether it's individual-based or group therapy sessions. And I've had the privilege of seeing some Fortune 100 companies over the last several years on what they're doing to innovate on that front, and it's been fascinating and really value-add to driving improved engagement and utilization, ultimately outcomes, and that's really what it's all about.
Hassan, employer innovation roundtable, so focus on bringing lots of innovation technology vendors and others together. So what's your perspective on the impact it's having on employers in general and worksite centers?
I'll do this in Klingon first. It's interesting. One of the things we realized when we talk to about 700 innovators every year that are coming through trying to get in front of our 110 employers. And one of the things that obviously not a day goes by when I don't hear something about AI and machine learning. Like everyone's got it. I get it. But what's interesting is from the consumer standpoint and the patients, like they want something that's always on. Like so we used to talk about, okay, I need a physician appointment in 5 or 10 days. Now it's I need something, I want to push a button and talk to a provider right now. I want to talk to a health coach in 20 minutes. I want a pharmacist to answer my question about the drug I was just prescribed. So that consumer-centric behavior and the demands of consumers is falling into the workplace and changing. And benefit leaders are saying, okay, now I have to look for a little bit more from my vendors because my employees, like they can't wait. They actually want that experience because I don't want to lose their engagement. So they're engaged at this moment. They want to talk to somebody. They want some care. If they don't get it, they will fall behind and they'll delay care or something. So that we're seeing a lot of what I call the easy button on my phone. Doctor, I'm here. I have a question. So we're seeing some pretty interesting things, even in the mental health space, where there's someone. Even if it's an AI response, there's some response that to actually pull that person into the system and get them engaged. And I think that's going to have an impact on clinics because the faster you can grab onto that patient when they care about it, you can pull them in and keep them in and get them to that in-person care.
Great, thank you. Kari, your perspective as a national benefit consultant?
I think as maybe 2 specific examples that I would give. One is we see a lot of clinics using e-consults or provider-to-provider specialty consults, so similar to what Tom was saying around you want that easy button. So that can really help to reduce specialist visits that are happening in the community. It can help get a quicker answer. You can connect to a specialist maybe same day within 48 hours. Sometimes we are going to need to refer right out to specialty care, but in those instances, if you can get that answer quicker, that's a huge benefit. Another example, I had a client who was working with a health center vendor, and their vendor had a partnership with a local health system in that area, and they used that handheld ultrasound device. They didn't need a full room for ultrasound, they didn't need all the machinery, but the providers there were taught how to do that, and then it was sent to the health system to be able to read that ultrasound. That's a huge employee satisfier, right? Because you're not having to make that appointment in the community, you're not having to then wait to get that appointment, wait for that to be read. So I think, again, just 2 kind of specific examples of seeing it in action in clinics.
Great. So, Jeff, from a national service provider who has on-site, near-site, mobile, and shared centers, where's the technology taking you? What is the impact of this?
I think the others have touched on sort of the member, the patient experience and impact a lot. So I'll come just from a different angle, which would be on how to use data or information to drive stronger insights. So from like a population health management point of view, looking beyond just an individual member, looking at the entire group, it could be hundreds or thousands of individuals, and then using historical claims data, pharmacy, medical, demographic information, and I think increasingly we can use clinical inputs, capture biometric values through screening programs, or even add to that more sentiment, psychographic, social data inputs, all to sort of identify how to prioritize which members have the highest need or are the most vulnerable. So the one thing that I think any of us that are involved in population health, insurance, employers, you recognize is healthcare cost and like morbidity or disease, if you will, are highly concentrated in a small percent of the population. So everyone needs something, but in terms of where real chronic condition or illness is, it's 5% or 10% or 20% of your population. How do we identify that early, anticipate, and I think the power of different data analytic tools are giving us the ability to sort of run maybe stronger algorithms to identify that. the technology won't do anything. All it does is serve up, where the opportunity is, and now, you need really strong process and really strong people to do something with that information. But I think that's a real leverage point for organizations.
Great. Phil, you lead the national pharmaceutical supplier, providing worksite centers with prepackaged and other drugs and opportunities. Where is technology taking that area as well as the others you're working with?
All great answers, everybody. Thank you. We could talk for days on this. I think one of the things we're seeing trend-wise is tools and technologies that actually empower the patient. And obviously the clients, we as self-funded sponsors of plans, obviously we want all the tools and data and getting the data when we need it. But for example, CGM, continuous glucose monitoring technology, we've seen great improvements in that. And what it does in terms of enabling a patient to actually manage their condition, manage diabetes with information that they can react to. To Jeff's point a second ago, obviously you can't make someone do something, but when you are empowering them with the right information and the right insight that they can actually react to it, that's a game changer. And I think that's really what the Internet of Things and all these monitoring technologies are really about. Is can we get the right insight, the right information to the right person where they can actually respond to it. So if I'm a patient, I can respond to maybe dosing. If I'm an employer, maybe I have information in a timely way that I can actually make a decision in a predictive way, an anticipatory way, rather than reacting to it. This notion of, and I think of it like smart information, right? Smart data is where I get it, and it's actually helping me do something with it. And we're also seeing very cool technologies around dosing. So we've got a couple of collaborations going around how we actually, pain management being one thing, which is a challenge area in many ways in terms of how it's monitored and managed, but also in terms of enabling patients to dose and access the right amount at the right time, tying into these technologies. And I think if we think in terms of things that are changing behavior or empowering, I think that's where we'll see and continue to see where technology makes the biggest difference.
Thank you. Hassan, are people comfortable with technology and the patients? I mean, we talk so much about health literacy, and we talk about health benefit literacy and being able to use devices and such. Do we have to prepare patients more, or what's the role that employer worksite center in making sure that these things would actually help?
I think so. With more younger generations being digital natives, so I think multiple generations working in a workforce, employers have to deal with, okay, not everyone's going to use this, not everyone's going to be comfortable, especially with a virtual first health plan experience or virtual primary care. So they have to have access for everybody, make it comfortable for it. So no, not everyone's, including in my own home.
Carl, what's your experience with employee populations technology?
Yeah,
Especially
I think I would say the same. I mean, I think it varies based on what's available. I would say one thing that we have also seen that's been impactful from the member standpoint is patient portals have improved too. We may kind of take those off and not think as much about those, but that's a real thing. And whether it be secure messaging with your provider, accessing your virtual visit through there, if you're using the same EMR with different providers in the community, being able to bring all of that together, see your lab results, get your education right there. You're in there with the provider and they say, I have some information about your newly diagnosed diabetes, and then it can be sent right there. So putting those tools in their hands, certainly, but I think, again, some of those things that maybe we've taken for granted for a while are continuing to improve as well.
Okay, Jeff, would you talk a little bit about patients and how to get providers comfortable with using the technology?
That's the easy part. I sometimes refer to, primary care as, if you just want to distill it down, it's influencing human behavior. And I think in my role as a leader in an organization, like 90% of what I do is try to influence human behavior in a positive or productive way. I was really struck, and I don't think this is a unique insight, I've heard so many people share the same, but through the pandemic, I think we accelerated sort of the adoption, just on the provider side or the clinical team side, sort of the adoption of newer or different technologies or different processes, we sort of accelerated by 10 years, and I think really pushed people to accept, like, you know, the level of change that they can actually successfully navigate. And, you know, it was just by necessity initially, but then I was really proud, at least in our organization, of our teams, that, you know, we're like, all right, I guess we have to fundamentally change how we work together, how we support, you know, patients, and they did. Now, some of those things were like, that's not really the best way to do it sustainably, and now we can go back, you know, to doing more things in person, let's say, but like, you know, we've increased by 300% the level of, you know, sort of pure digital or virtual care interactions that we had pre-pandemic, probably more than that actually. But yeah, I don't know that I have a great insight other than like the classic things in terms of really how do you get folks to, you know, adopt a new process, a new technology, a new way of doing things. It's like the more we can include people in the process, be really transparent about the why. So why are we thinking this change happening? Try to bring people along, you know, really constant communication.
Bill, from your perspective, what's the patient perspective on this technology?
I think one of the things that's happened to us over the last, whatever, number of years, is we've gotten used to a poor experience. Whether it's in a health system or in a health encounter. And I think the opportunity, and if you think about the clinic model itself, it's really about experience. It's about bringing that closer and removing barriers so that it's a good experience and it encourages a member or patient to take care of themselves. If we start to think of technology as an enabler of experience, Karen mentions portals being better, how we actually interface with the technology, how it actually helps us get to where we need to be. What we don't want are barriers. We don't want things that inhibit us or make it harder to get what we need to do, so that the complexity factor of that. So I think we're going to see a wave around, continue to see a wave around this experience notion, both in terms of the digital, I mean, how we're interfacing, where it sits, the devices we're using, but also then when the analog, when we're walking into a place, when we're experiencing, encountering, interacting with our physicians, with the staff, with just the facility, and then on through into the health systems, which is likely the biggest opportunity for an improvement of overall experience we can possibly have. So we need to start thinking in terms of the technology as an enabler of that experience and removing the barriers, rather than the control point, the choke point, the focus point, the thing that we lay on top of somebody and force. It's about how do we help them actually experience it in a better way and empower them.
Thank you. Jason, you had benefits from Boeing. How do you get people up to speed on new technologies and make them comfortable with it? Do you have to actually teach them how to use a computer or get online?
Yeah, we had a very diverse workforce at the Boeing company, and you know, we had employees in all 50 states, 65 countries around the globe, but in the U.S. alone, 90% of our entire workforce was U.S.-based, 10% overseas. So in the U.S., all 50 states, urban, suburban, rural zip codes, people everywhere. And it's really difficult to provide a level playing field when we think about healthcare access and affordability. The thing that we found very successful was, and David Hines, I'll give you a ton of credit for this because I think you're doing it the right way. You're giving it away for free. So you're removing those barriers around affordability. And the reality today is over 1 in 2 Americans are living paycheck to paycheck. 100 million Americans are grappling with some level of medical debt. So we need to be mindful with our plan design as far as employer benefit strategy leader stewards, as far as creating constructs that can address the diverse workforce, whether they're white collar, blue collar, hourly paid, salaried. We saw major disparities looking at our benefit data warehouse and our claims data, just specifically looking at dental, for example, where our hourly paid production workers were more incentivized to not just work maybe a first shift, but work a second shift for overtime as we were ramping up production rates on Build a Dreamliners in South Carolina. And what we learned from that was after working overtime, they wanted to take time to sleep or take leisure time with their family. But what was getting compromised was they were bypassing the 6-month routine preventive dental cleaning exam that, you know, ordinarily you would take full advantage of because it's free, or even going once a year. they were just bypassing that altogether. So the light bulb moment went off in our head to do a pilot bringing Onsite Dental to Charleston, South Carolina, no wait time, full service dentistry. And what we found after 1 year in with this pilot was the biggest users of Onsite Dental was the hourly production workers that hadn't seen a dentist in 1, 2, 3 years in some cases. But you're meeting them where they're at, and you're making it very convenient and easy so they can conveniently come before the start of their shift or after their shift ends and take care of any kind of dental work that's needed, or even preventive for that matter. So there is really positive impact that we learned from that experience, and it was very easy to set up from a technology standpoint an appointment from their laptop, their desktop computer, or mobile device with no wait time. But the learning out of that really sent the aha light bulb moment in our head to say, hey, what if we took this great experience in South Carolina and went to Puget Sound, went to Everett, where we're building all the other commercial airplanes, go to Renton, where we're building 737s, and really scale this up. And that's exactly what we did right before the pandemic in January, February 2020. And we had great success in the early months, and then we had to suspend for all the pandemic reasons, but with an aim to return that back after we got to the other side of the pandemic, and that has carried through. So from a technology standpoint, Larry, I think the real point is we had hourly paid workers that never bothered with a mobile device. So we had to get very creative on our communication strategy to connect with them where they're at. It might be the cafeteria when they're taking a break. It might be sending a postcard to their home. And oftentimes we found that while 3/4 of our workforce were male, it was typically the spouse that was the quarterback decision maker for their healthcare decisions and what they tap into. So we saw great success as far as connecting through a myriad of what I call surround sound marketing to engage members and enable them in a multimodality way, whether it's laptop, telephonic, mobile device, you name it, or just go in person to set up an appointment, for example, with Onsite Dental, and get whatever care they need done. But get it done free of cost in most cases. In other cases, we would integrate it, like for the dental example, with our existing dental plan administrator, so everything the network and preventive was free.
Thank you. Carl, can the technologies help an on-site and site center sponsor deal with health equity and social determinants of health?
Yes, they definitely can. So I think when you talk about social determinants of health, that's a buzzword, has been for a little bit now, right? We want to think about it from, I think, the provider standpoint, the tools that the provider has, but also what the member has. So there's all of these things like findhelp.org, put those tools in front of your employees and their families to be able to search by their zip code for resources around different social determinants of health, whether it's transportation, financial insecurity, those types of things. But we really also need to arm the providers with this type of resource as well. So it might be within the EMR having assessments that focus on social determinants of health, including this as part of the preventive exam. Ensure that the EMR is also notifying when the person comes in for a follow-up. Last time we talked about this, they were having issues in this particular area or concerns in this particular area. And so think about the member holistically and certainly kind of bring that in to the conversation as well.
Jeff, any comments on how they deal with social determinants of health and technology?
I think just building on Kara's comments, I mean, technology is an enabler, and I think, process is probably the most important thing, right? I mean, if we only think of, sort of primary care or an on-site health center, it's like, let's just go hire a provider, it's a nursing staff, medical assistant, provide whatever scope of services you want, hire the people, stick them there on site, and all this magic happens. It's like a pretty limited view of the potential, right? It's more about how do you actually intentionally design a process or a system of care that looks different, that feels different, and Kara hit on a bunch of tangible examples of that. You can use the technology to build it in, but it's really the process design that actually makes things different. Maybe on the social determinants, I just highlight like time is, I think, the most valuable sort of input to really, really good primary care. Right? And like any good family physician or family nurse practitioner, when they're doing just an annual assessment and building a relationship with someone who's going to start asking about, do you feel safe at home and how's your relationship going and like what are other challenges, financial or otherwise, that cause stress. When you collapse that to like a 7-minute visit and here's all the things you have to do, you just can't do it all. If you can extend that and say, well, hey, an average appointment would be 25, 30 minutes, more complicated, maybe you need 45 minutes to 60 minutes or something like that, then all of a sudden that allows for a different level of conversation to touch on things that actually matter to people.
Thank you. Bill, comment on that?
I think the only thing I would add is, so it's not any one fix, right? It's a system, it's a process of things. I think if you look at the hierarchy of needs, so people have to be at a certain place before they can actually take care of themselves. So a good friend of mine always talks about the overwhelm of life, of things that they're experiencing. So knowing how we can get through that, I think having a way to engage from a clinic perspective to do that is good. But I think for us, if you think about the system of it, it's really more about making it easy across the things that we do, the things that we offer. I was at a vendor summit probably a year or so ago, and there was a line with a particular client. We had all these different point solutions and providers and different things, and they all had great services, but they were all in their silo. And what you realize is trying to hand off between those, that's complexity. It's a barrier, and it's not always easy. I trusted Jeff, but I don't know this other person, or I got in this situation, how do I know that this will work, or I didn't get in the first call. So for us, we go and we put all these right things in place, but often how they're implemented, how they're executed, that's maybe even more important than what they are. And finding ways to facilitate that, streamline that. I think technology can actually be part of that in terms of helping navigation, information, the empowerment for people to actually know. But I think there's good design needed so that when we think about how someone moves through it, what's actually happening? What are the points where we're going to trip, or this could be a barrier, or there's another thing that pops up that actually keeps us from taking advantage of it? We have a wide range of demographics in our employee base, and I watch it every day. The phone calls in the hall, or the different things that they're fighting with. And you think, how do I help? Not that I can solve, but how do I help so that they can access the resources, things that are available to enable that? And I think it's something we have to continue to challenge ourselves with our clinic relationships, also with the other services, and how do we make that as frictionless as we possibly can.
Please.
One of the things I've noticed over the past few years is about 4 years ago, employers, they didn't know what social determinants of health was. They didn't know the difference between health equality and health equity. And now they're more savvy about it. And what's interesting when I'm listening to what happened at Boeing, employers are used to looking in the past at social determinants. Okay, last year this is what happened. But now they're looking at their vendors and say, before that happens, next year, I want you to go out and pull those people into the system, to find people in those food deserts, find people that don't have access, and actually get them before we have a problem, and actually correct the inequality before it actually takes place. And we're seeing some really interesting uses of data across vendors in different spaces. So it's great to see progress on it.
Thank you. Jeff, let me ask you, the technologies that are coming out now, is it leading to more fragmentation in the healthcare system? We've got all these vendors who now have pipes of an employer's data. We like to think of the worksite center as the hub of the wheel that connects to all the benefits, but are these causing problems, or are they enabling greater access to people, or how do we avoid, again, the employer losing track of their data and the provider at the center knowing the totality of the patient's care?
And so I think on the one hand, the proliferation of these different vendors, point solutions, is probably exceeded the point where it works seamlessly well for either the member, to Phil's point of like how do you navigate that without confusion and friction, and just an administrative burden, I think. we work with over 200 employers across the country, with very diverse industries, sizes, and so forth. And I think the average number of health delivery related vendors, sort of benefit vendors, if you want to kind of capture it that way, the average is 14. We have some partners we work with that have 30. Everyone has many. And so I think just that proliferation is creating friction in itself, and we're starting to see the market move to say, well, I think consolidating or collapsing some of this is going to be more advantageous for both member engagement, better member experience, ultimately better outcomes, and just administrative ease and probably some cost savings. I do think technology is an enabler here, though, as well, in the sense that it's easier now to share information or data with one another. So even if you do have 3 or 4 vendors that you want to work collaboratively together to meet a member's needs, and you want them to be able to have access to relevant information sort of across the ecosystem, the tools are a lot easier. The pipes exist, and there are more standards that we can work off of with healthcare-related data. Security certainly is important, but again, I think there's industry best practices and a lot of published standards around how do you make sure you've got the right certifications and the right kind of practices in place to ensure the security of that data.
Thank you. Hassan, let me ask you this. EHR looks at all these different vendors and vets them from employer. How do we avoid fragmentation? How do you bring it all together? Or are these vendors actually suggesting they can do that?
Well, employers are very good at unbundling things, so I'm guilty of charge. I've broken apart the healthcare system over the past 20 years and told employees, well, if it's Tuesday, you go get this over there, and Wednesday, you're going to go to this for there, and you got to use this vendor, and if you're this tall, you have to go over there. And I think employers realize that that's not working, and so they're looking to bring all that together for this whole person care. And I'm not going to get Jason's company plug, but I will for a second. So like companies that are looking at like Vita, at the whole person, and saying, we're not just treating the person with diabetes, we're treating them with a mental health issue, maybe they have a social determinants issue, they may even have some problems financially, and so we have to pull all those things together and not just treat them with some of the different parts of the health system. Unfortunately, there are still vendors out that are point solutions, and they're fighting for their survival. And so they say, no, we're gonna hold on. We're gonna treat this one little thing, but it's actually it's creating some waste in the system, unfortunately. And so employers are looking very carefully at all of the things they bought, especially since the beginning of the pandemic, and saying what's working, what's not working, both individually and as a whole system, and how to actually treat my population more efficient and effectively, and they're finding that this whole person care, unfragmented, is the best way of going about doing it. So a lot of employers are going to have to undo what they've learned to do over the past few years.
Thank you. All right, let's shift to trends. Let me ask Phil, what's the trends in pharmacy that you see moving forward, and how are PBMs reacting to worksite stuff?
That's a loaded question. A lot of trends in pharmacy. So I'll just touch on a couple of things. First of all, costs continue to go up, which is an unfortunate trend. There's also things attached to that, though. There's treatments in that. So let's talk weight management. There's a coming tide of the GLP-1s. Has anyone not heard of a GLP-1? Just checking. How many people actually have them on their plans right now? Yeah. How many think that they're going to have them on their plans sometime next year? You probably will. The trick is not how you avoid, run away, or fear these things, is how you engage with them. So what we're seeing are programmatic ways to go out and address particular disease states. We're seeing pharmacy options and pharmacy opportunities for engaging with the clinical side to actually bridge it in a way that you're actually getting the right meds in the right place at the right time. If you think about the notion of stewardship, which is something that we like to really talk about, you have an employer, a sponsor who wants to steward their money in a good way. They want it to be an investment. They want to get a good return on it. They also want to steward the health of their members in a good way. And you have members who want that. So it's how do we engage them so that it's easy. So the barriers around cost become a problem. Right now, today, we have big levers where we either raise co-pays or deductibles, or we shift costs, or we carve out. The trick is, can we acquire it for the right price? Can we get it to the people in the right program at the right place at the right time so they're using it properly? Can we make sure it's actually effective? That's a lot in one place, but there's actually a lot happening from the pharmacy side, and the need for even PBMs to move, which by the way is a four-letter word for those of you that don't know, PBM is a four-letter word. We like to call it Pharmacy Service Administration. But where you actually, the PBM becomes its own silo, where it's sitting out over here doing its thing, and people are like, what's going on over there? It's bridging that over into what care is happening across the spectrum, so it's actually engaged in the care and not sitting out in its own place. We're also seeing this trend. I don't know if it's a trend. Transparency, I guess another buzzword. And so if you really take transparency, what really we're asking for is we're asking for trust. We want to trust that what you're saying is true. We want to trust that what you're doing on our behalf is actually what you told us you were going to do. We want to trust that the price you said it was going to be is actually the price. And so what we're seeing is this trend towards honesty, towards going in and saying this is what the cost of a particular product is, going and saying these are the products that work, these are the products that don't work, towards going and saying here's where you might need a GLP-1 as part of your program, and here's where you might not need that. Going and assessing complex specialty therapies that are complex, and making sure that those are the right thing for your patients. Sitting down with your clinics and your healthcare providers to help the employer with influence and bringing the drugs to bear within what that is. I think what we're seeing is which is Hassan's point about kind of deconstructing a lot of these pieces and then reconfiguring it in a way that actually gets results. And the great thing about this is the data we see, we work with probably 1,100 or so employers across our book of business, about 500,000 lives nationally. And the neat thing is if you can break this down into small enough places, you can actually get measurable results. You can actually get the ROI on it. So I think the trend is to bring it down to a lower point of influence, the lowest common denominator, if you will, the member of the plan, that point of influence, and then focusing on what we can do to make that happen. And I think that we're seeing the pharmacy side being integrated far more with the clinical side, particularly as it relates to groups that are able to sponsor near-site or on-site health centers.
Thank you. Kara, what are the trends in worksite centers? Are employers looking for on-site, near-site, virtual, more shared? Where do you see as the national leader in the worksite center?
Yeah, we continue to see a mix of all. Honestly, there has been, even before the pandemic, there has been more interest in shared near-site. Folks that have had an opportunity to see the benefits of an on-site really believe in it, but maybe they don't have enough of a population to make it make sense somewhere else, had already been thinking about shared near-sites or implementing shared near-sites. I think the big component of this is there's not a health center strategy anymore that doesn't have a virtual component. And when we think of virtual, it's in three different ways. It's table stakes now that you can have a virtual appointment with your health center provider during health center hours, right? That is expected for primary care, acute care, behavioral health, even physical therapy, some of those types of things. What does after-hours support look like? Is that through your health center provider? Is that through another virtual component that you have? But it's also going back to equity. How do we think about a similar experience across an entire population? There is more interest in virtual primary care. So again, where maybe you don't have an on-site, maybe there's not a near-site already for you to jump into or add on to. Thinking about virtual primary care for the full population, that's something that more and more employers are looking at. Maybe they haven't moved forward yet, but they're very seriously considering for their entire population.
Thank you. Jeff, could you comment on that direction as well? Marathon has invested a lot in network solutions as well as taking on some other firms. What is the direction you're seeing for this industry?
I agree with what Kara said, and I think you have to recognize, one, that employers are diverse in their needs. And so, if you're a certain type of a manufacturer, industrial, agricultural business, and you sort of have like a plant workforce that isn't is all there with certain size and scale, there's probably no better way to provide access than having a physical, dedicated on-site, sort of dedicated near site at the office, at the manufacturing plant, on the campus. But for other maybe professional service organizations or those with a field workforce or in a hybrid work environment, they're just not coming to the corporate office like they were maybe 5 years ago. So you have to drive engagement, drive outcomes, you have to meet members where they are. And so that might be a near site or sort of a network strategy. Network within our organization, it's really, it's a purpose-built set of near site health centers in a dedicated geography or market. And our view is that for a lot of America lives kind of within the bounds of the 140 largest MSAs, and so for many organizations, if you want to drive access, having physical access points in those markets makes a lot of sense. But I agree with everything that was said around virtual. It is both a channel and a dedicated sort of solution, if you will.
Thank you. Jason, comment on the direction of OSAT's thinking?
Yeah, this goes back to the data analytics and the trends that we've seen emerge over time. The pendulum has shifted back, and I've seen this in my talks with employers practically every month. The 14-point-based solutions that were launched with the best of intentions, as Hassan and Jeff noted, is real. What we've seen over time is generally suboptimal industry engagement, utilization, enrollment into those well-intended solutions that typically were narrowly focused with a singular core competency. So, best of intentions launching what was viewed or perceived as best-in-class solutions, typically with a narrow core competency. And this pendulum has shifted back, and it's continuing to shift back towards simplicity. How can we optimize that employee experience? How can we bring more solutions that are value-based by which the vendor partner, the solution partners, willing to put 100% fees at risk, guaranteeing clinical outcomes. If they don't deliver, you don't pay. It's simple as that. There's very few that are willing to do that in the market, but this focus on value-based care and 100% fees at risk is true, along with the transparency on pharmacy, and we're seeing a lot of clever PBM contracts that is also moving the needle around getting better line of sight and moving away from the shell game shenanigans that have existed in the status quo models and getting towards more of an acquisition cost plus model on pharmacy and transparency, and also flexibility to have the right as the employer or as a plan sponsor to engage in direct contract with any entity at any time for any reason. And that could be a direct contract with a pharmaceutical manufacturer as far as how they want to engage with the procurement of pharmaceuticals flowing through what traditionally was just a one-stop shop in the PBM side. But we're seeing this convergence of trends around whole health, as well as Hassan mentioned within Vita, that literally has nearly 20 solutions all under one umbrella, one patient experience, one front door, to simplify that employee experience. So if they have a polychronic state with type 2 diabetes, hyperlipidemia, COPD, CHF, we're seeing a 70 to 80% prevalence of some underlying anxiety, depression, stress through a GAD and PHQ that oftentimes is untreated, undiagnosed. So when you can take care of what's going on the chronic stack, along with the mental stack, along with obesity, hypertension, GLP-1s, weight loss, nutrition, and bring a human-centric approach. Not a tech-only approach, but a high-touch, human-centric, tech-enabled approach, leveraging machine learning and AI, and taking care of the whole person. I believe that the health plan carriers, because they've said this on stage, the PBMs that are typically vertically integrated, and many of the innovators back 10 years ago that launched maybe solely as a diabetes management solution or a primary care virtual solution, have morphed through M&A, organic build-outs, as well as inorganic assets acquired to create this whole health construct. And I think with the on-site clinics and the near-site clinics, they've come a long way as well. So this convergence of technology and meeting people in the best way possible to deliver the absolute best patient experience and clinical outcomes, that's the secret sauce. That's like the holy grail of what I think all of us are trying to figure out. How do we integrate and harmonize what we're doing to achieve that so it's going to be best in class and very unique and differentiated. but it's also going to be predicated on value. So we're seeing pricing models change, the technology, and certainly the evolution with all these different stakeholders.
Great, thank you. Sam, when you look at the worksite centers in your direction, is there technology employers and centers are not taking advantage of, or something they should focus more on?
D, all of the above. I think a lot of employers are trying to figure out exactly how to integrate different technologies into their whole strategy. So probably not a week goes by where I'm not talking about, okay, what do I do about genetics and genetic screening, and how does that fit into our primary care strategy? So a lot of employers are going out and contracting with companies like Grail, well, I shouldn't say a lot of companies. Many companies are looking at companies like Grail and others that are trying to figure out how to actually do genetic screening for employees to, again, identify risks, help people manage their condition before it actually exacerbates itself. But what's interesting, a lot of employers we're working with right now have spent so much time focusing on acute care. So I'm trying to manage the cost of surgery through bundles, through directing my employees to the right hospital networks, and they've kind of forgotten about primary care over the past few years because at DHR, our employees rank every few months what they're working on, and so I know what all 110 companies are about to do. And none of it has been focused on primary care or clinics because they're going after the big dollar things, the PBM and the actual acute care costs of their plans. And now they're looking, they've quote solved that. They've solved the MSK. They've got a better PBM contract. And so they're saying, all right, what do I do on the primary care side of things? So some really interesting companies coming through with virtual primary care or primary care centers of excellence. We've seen quite a lot of interest in women's health, not fertility. So a lot of employers have figured out their fertility strategy and they have access to clinics. But they're figuring out how do I pull women into primary care, connect them between visits, make sure that their maternity journey is actually well managed and that they actually understand their risks. And we've seen a couple companies come up in men's health. Men are not great at going to the doctor. And so we're looking at a company that's actually, okay, so if they're not going to the doctor, let's bring the doctor to them. What testing can the man do at their own home? So trying to find different ways, again, to pull people into the primary care system.
Thank you. All right, so we're my final question on the round, and then we'll ask audience questions. Kara, what are the success factors in the future for on-site and site centers? What do they must do?
I think the easy answer is accept virtual, use virtual in the ways that you can, integrate with the 14-point solutions or the 14 other solutions that you offer, but continue to use the data that you have, whether it be through claims data, health information exchanges, remote monitoring, to empower the member, but also to empower the provider to provide that high-quality care.
Thank you. Jeff, same question. What are the success factors needed for centers?
So maybe I would focus more on the sort of key performance indicators, if you will, right? And so I think it comes down to, like, number one, are we driving engagement, right? And so objectively, are people engaging in using the service? Are they coming back and using it again? How's their experience, right? And so you can look at surveys, whether it's Net Promoter Score, overall satisfaction. You can go deeper on that. Third, are you objectively driving outcomes? So are you getting better control of the chronic conditions that we've all touched on? Are you getting increased rates of preventive screenings? Other sort of quality indicators around sort of the health and well-being status. And then finally, are you reducing cost? Right? And there's a few different ways to do that, but I think you can start overall look at, sort of on the front end of these partnerships, what do you forecast your trend to be overall? And then, sort of with all the strategies you're putting together, increased investments in primary care, are you able to sort of moderate that trend? And you can also look at users versus non-users. So those that are actively engaging at a higher level with the primary care solution, with your health center partner, are they, over time, using the same amount or less of healthcare resources? So is utilization going down, and just you can look at per month cost? And are we seeing that go down to this group and make some adjustments actuarially and so forth? But I think those are the things to focus on.
Thank you. Phil, your perspective on success factors?
So we see a lot of different approaches, like everybody here does, in terms of what people you're doing out there. I think one of the first things we often do is say, don't boil the ocean. I think we all tend to look at it like this and say, oh my gosh, I've got all these things I need to address. Then we retreat back, we chase back, and then we go to 14-point solutions to solve all the individual problems. I think you've got to take a value-based or risk-based approach and prioritization. So what I mean in that is that we've got to start thinking in terms of where are the big costs and what are the things I can actually manage and attack on the front side. And as I move down the list, then are what are the big risk points, either health risk-wise or risk to the organization, risk in terms of medications, and how do I mitigate those things and prioritize around that. I think we tend to look at the world so broadly that we kind of miss a lot of individual opportunities. And I think Son may have talked about, or maybe I think Jerry you did, about simplicity and how we kind of get it down to where it's something we can really navigate. That's for both for us as employers, sponsors of these plans and these things we're doing, as well as our members, and how do we remove as much of that complexity, those barriers as we can. I think that's a huge opportunity for us. And I think what we're going to continue to see trend-wise going forward is, particularly around worksite clinics, is this notion of nexus of care. All right, my turn, I'll claim that. But I think it's the mental thought that you're putting money into something and you're wanting influence, you're creating this nexus around which you're doing all these different things. And how do I philosophically manage that most straightforwardly so that it's all integrated as much as it possibly can be, from our clinic on down to any particular program we got implemented. And I think you can do that by basically going back to the prioritization approach of saying, what are the key things? So whenever we go in and we kind of go through the list of problem areas, we always start with 3. I don't know if 3 is a magic number or not, but it's always kind of 3, the 3 places we can start with. And then as you make progress on it, then you realize, all right, I don't have to deconstruct and rebuild this all in a day. I can actually have a progressive plan that actually bridges from today to tomorrow, and I can put the things in place to address it. And then I can react as things change, because I suspect they're probably going to change again. So I would say, don't boil the ocean. Focus on trying to come to a point of simplicity. Look for the integration across it, and really think about it in terms of experience, both in terms of the complexity.
Jason, success factors or move forward?
Yeah, I would keep this very simple. When I would talk to business unit leadership at Boeing, there was only one thing they cared about, and it was productivity. So what you do as a benefit strategy leader, you have to figure out how to tie what you're looking to do in your business case, especially if it's going to be a costly investment with real estate and repurposing, underutilized space to stand up a clinic. How are we not only going to focus on what we would look at as, AAA value-based framework around patient experience, optimizing that, clinical quality outcomes, improving that, and financial efficiency, ROI, return on investment. Those are all mandatory. We need to address those 3. But how do we tie back, what does that mean to productivity in terms of improving the productivity of that plant, that manufacturing plant, or that work site that has the critical mass? And I think the business case will sail through in flying colors. We have a really well done, we would take a 5-year forward pricing actuarially and a very conservative financial modeling exercise to really understand the puts and takes. What's the investment? What's the ROI? What's the impact on the other factors with clinical quality improvements, which can be much greater and better based on the disparities of healthcare quality in America, which we know is very wide. But how you tie that back to productivity, I think, is the secret sauce, at least for a manufacturing company and many others. As far as what you're doing with the on-site clinics, Larry, I would tell you, primary care, absolutely. That'll probably account for 40% of your visits and revenue derived within that structure. MSK, especially in a manufacturing employer, you're going to see a ton of physical therapy opportunities that might be non-occupational health related as well as occ health related. But how do you address PT, MSK? Huge area of opportunity. And then for the last 4 years in a row, being an EHR alum, We saw through the survey of 110 employers, mental health was the #1 priority out of the top 15 over the most recent last 4 years in a row. So how you weave in mental health, behavioral health in concert with the primary care MSK, and I would tell you, based on my successes with Onsite Dental, and then layer in vision for vision exams, you have a very competitive solution set with no wait time that's going to be focused on a value-based contract that will really move the needle. But at the end of the day, it all ties back to productivity because the site leaders that run the plants typically carry the go, no-go decision as far as their willingness to make that investment for it. And I think there's a lot of good you can do to tie that back to what matters most to them.
Thank you. Finally, Hassan, any comments on success factors for workspace?
ROI.
Okay. All right, with that, let's go from questions. So again, write your questions down on note cards. If you'll hand it, just hold them up. Our staff will pick them up. But I've got a couple who were brave enough to send me something. So this is generally for the panel. Anybody can comment on it. Question, well, it seems to me technology is not the answer. Relationships are. That all technology should be judged as how it enables relationships. Also seems to me company culture is a secret sauce. Do companies understand that? If not, how do we help companies understand they have stewardship responsibility and a duty and an opportunity for their people? Comments? You shy. Go ahead.
Would you repeat the question? What was the last part?
Okay. How do we help companies understand they have stewardship and responsibility and a duty and an opportunity for their people and developing these relationships and culture in the Maple Site Centers?
Culture. A great concept. So I think my comment on that would be philosophically, why do we provide benefits? Right? Why do we do this? Productivity may be the answer. Although I would argue all day with that too. Because we've got a lot of things to break it down. If we can't think about the why of that, you want someone to thrive. You want someone to benefit. You want them to take that and actually do the best they can for your company and for themselves. And that's what culture is. That's what that's about. Now, if your culture is productivity, then you have to understand what the priorities are within that, how you communicate that. I think for us as people serving on the health side of it, we for the most part are in organizations, and I know that I can't think of a single client of ours who doesn't have a serious heart for what they're doing, a serious desire for it to provide good things. So I think the alignment in that comes in how we're consistent across all facets of what we're providing, how we communicate that, how we tell the story, how the narrative of it comes from the heart. If we approach it as productivity or as a straight ROI on all fronts, we're gonna lose a big part of the humanity in that. And that may sound a little soft, but I firmly believe that if we start with the idea of how we get that person to a better place, a lot of the other things will work themselves out. And I think what I've heard a lot from a lot of folks that we work with, and even today, is about how we're removing the barriers to make that happen. So I think the culture question is a great one, and I know that everyone's got their own challenges around that, but we've got to start with that.
If I can just maybe add one more component to that is don't be afraid to do employee listening. This has been something that I think employers have embraced more over the last couple of years around what are my employees saying about their well-being. You can do it for those who have access to a health center, users versus non-users. Why are they using it? Why are they not? But think about whether it's through virtual focus groups or surveys or even just pulse flash surveys. Listen to the employees. Doesn't mean you're going to implement everything they want, but hear from them, listen to what their concerns are and what they're saying to help build that kind of culture as well.
Great, thank you. Jason, there's a question about the on-site dental you mentioned. Can you talk about the value of that and if you're comfortable with the names that you're going to use?
Yeah, so believe it or not, it's Onsite Dental. They launched over 20 years ago, or close to 20 years ago, with a pure focus just on providing full-service dentistry on site. And I never knew about them until around 2015, 2016, when I had the opportunity to go to Facebook headquarters, now Meta, one hacker away. And they just stood up a 20,000 square foot on-site clinic, which just blew me away. It was unbelievable. And the thing that I never really thought of when I thought about on-site clinic was the importance of also offering vision exams and, point of purchase with lenses and frames and safety glasses, along with full-service dentistry. Just never really crossed my mind. Well, that intersection, as far as those two areas into it, made a ton of sense. And when we were looking within our claims data, within our benefit data warehouse, we saw striking disparities, again, in the utilization of healthcare in general. But dentistry or dental claims was one clear difference with our blue-collar, hourly paid employees for all the reasons I mentioned earlier on. If they can make an extra buck or go on vacation or spend time with their family, as opposed to taking a half day off and not getting paid, it's an easy, answer as far as how they were looking at it. So when you bring that forward to them, we did it on a cost-neutral basis. So it was a mobile trailer, fully customized, and they did everything right there at the Dreamliner plant in Charleston, South Carolina, and it was unbelievable. So from there, we were trying to ideate, well, how can we find some underutilized real estate space to make that pivot from full-service dentistry into this beautiful customized mobile trailer into a brick-and-mortar setting in a hub, co-located next to our cafeteria. So that was kind of on the drawing board as far as various options that we could tap into, and then over time bring in, a more robust on-site clinic solution set for that particular location.
Thank you. We only have time for one more question. Jeff, I'm going to ask you to try to address it. 18% of our population has 85% of the cost of chronic disease. How do we engage, how do we target getting those high-risk chronic disease people to use our centers?
So I think you want to start with data, so you understand for your organization what's driving it. We've talked about the categories, obesity, metabolic syndrome, diabetes, depression or anxiety, probably chronic pain or musculoskeletal related issues are the key categories. But you can precisely figure out, not only who has one of those, but who has polychronic or multiple conditions. They show up historically in your data. If you can use lots of carrots, right, sort of use extrinsic motivation to get your entire population, if possible, engaged, you can also then capture data that doesn't show up because they haven't gone and there's no claims that would flag the risk. So I think you start with data and you start with engagement programming to sort of identify where the opportunities are. Then I think you have to unlock intrinsic motivation, right? And then someone earlier, the question was about like relationships and trust. I think that's exactly where it starts, right? If people want to begin, you could have a blue collar workforce with middle-aged men and be like, yeah, they have no interest in engaging. That is not true, right? I've sat in the exam room with, a 50-year-old, machinist or firefighter, and they'll cry. I mean, human beings are human beings, and they want to feel better, they want to address pain, right? They just may not be comfortable asking for the help. And if you can kind of, give that opportunity, people want the help. They will seek it. You just need to create, I think, the opportunity to personally connect and figure out how do I intrinsically get you to want to take the next step.
Thank you. Let's thank our panel for... All right, so we're